even if you're looking at perimenopause, it could easily be a 10-year window. You could be at different stages of that journey. The very definition of perimenopause is those fluctuations that women experience. So one day your estrogen may be super high, a week later it could be in your boots.
So Anna, thank you so much for
worries.
joining us today. We have a real life menopause GP specialist with us, which I'm so excited about. Do you want to do a little introduction about yourself?
So first of all, thank you very much for having me today. I feel like we need to be talking about those issues more, and it's such an important aspect of my daily work. So I'm a GP by trade. Way over 10 years I've been a doctor now. I've worked for 12 years in the UK. I did majority of my specialty training there, and then 7.5 years ago I moved to Australia. And this is, I'm in a second surgery now compared to where I first started. And now I've also have my little menopause clinic in this lovely centre here at Drift in Clarkson. So that's me.
Yeah. And how did you become a specialist in menopause and perimenopause?
You know, it's been a bit of a journey. I realised probably about 5 years ago or so that I don't want to just be a sort of pill pusher, and I wanted to get into root causes of different conditions. And the journey for me started with the Australasian College of Environmental and Nutritional Medicine, and it's not just sort of women and hormones and all that, but just, you know, the underlying causes for majority of chronic conditions. Then I sort of deviated into Hashimoto's, so autoimmune thyroid conditions, mainly because I am affected by it myself. And, you know, just having to sort of dig deeper into the sort of connection between the Hashimoto's, the thyroid hormones, and then the female hormones sort of started me on that journey.
Yeah.
So that it just happened gradually. It didn't happen overnight.
That's a really good segue into one of my questions, because while I was struggling to get help, because I went to a lot of GPs with my problems, and unfortunately most of the GPs I saw were men, so none of them identified that the problem was perimenopause, or what was happening was perimenopause, and I was sent for all sorts of tests, including for Hashimoto's and celiac disease and loads of things. And I think one of the things that I've realized or recognized is that there's such a crossover with perimenopause symptoms and other illnesses, and I was just wondering, I mean, that's a lay person's what's the word? That's what I've identified as a lay person. What do you think as a GP?
Well, I think first of all, we don't function in a vacuum, and there is a massive big sort of intertwine between the various functions of our body. And even with things like Hashimoto's, you know, you realize, oh, you need a bit of progesterone to actually activate your thyroid hormones. You need good microbiome for your thyroid to function. So you just sort of start looking at those different aspects, and you realize it's really just one thing. And then, you know, there is a reason why people have Hashimoto's more frequently in sort of perimenopausal and menopausal years of our life, because generally more autoimmune conditions come to life in that phase of our life. As it happens, and we could, you know, talk about it maybe some other time, we see more of the autoimmune conditions now at ages that we wouldn't normally associate with. But yes, you cannot just look at a woman in just this, you know, it's easy to go in a rabbit hole if you just focus on one symptom and don't have a look at the sort of holistic approach. And it's difficult, you know, especially when you come in for a 10-minute consult and you mention a few things, and, you know, you're often being told, well, pick one. And then we sort of go that way. Okay, so you've got insomnia. All right. We're going to be very patronizing to tell you that sleeping tablets are not good for you, and, you know, what are you doing wrong? and maybe give you something. And often we just don't look at the general approach. Oh, what else could be happening there?
Yeah.
And that's something that needs some work done, I think.
Yeah. So how do you approach it then that's different, that helps women in this stage?
I think it's important to listen. I mean, look, nowadays women, I feel like, because of the social media, because of what's been happening in the UK, for example, there's been Davina and everybody else that sort of sparked the interest in menopause. Women often, put it to you on a plate. They actually come and say, look, I've done my research, this, and that is happening. What about, what's your thoughts on me going through perimenopause or menopause? But sometimes they don't know. I had a lady the other day actually, and she came in and said, look, I've tried this antidepressant, that antidepressant, this one, that one, and those sleeping tablets, and none of them are helping. Is there another one? And, a lady, she was 51.
Yeah.
And she didn't think of anything, because nobody, she was conditioned that way that, well, it's your underlying mental health.
Yeah.
And that's what we're going to approach here. And we're going to find that pill that is going to, specifically help you tackle those mental health conditions. And so luckily she was very open-minded to, have you thought it could be your hormones sort of question? But it's tricky. It's tricky especially in a sort of 10-minute consult environment. Hence, I'm doing this because you feel like, I can send patient a questionnaire, so I've got a better idea of what's going on before they even come through the door. Yeah, okay. And then you just let them talk, and you fish out those elements that are helping you, those little pieces of puzzle that help you work out what's going on.
Do you ever extend your consults? I mean, because now, like if I go to my GP, I can choose an extra long consult.
Yes.
But would you consider having a perimenopause or menopause consult specifically to say, look, it's better to have a longer consult in the beginning?
Yeah, look, I often just run late. Basically, that's what happens. So I'm not going to tell you, oh, your 10 minutes is up. There's a big red button with a catapult. Off you go. So no, I think where it's needed, we just talk, and just get to the bottom. I often, and I don't know, maybe we talk about it a bit later, but I often do testing. So just to have a bit of a better idea. So there's always a bit of a follow-up as well. Yeah. So it's not just sort of one fits all. There you go. There's your hormones. See you never. Make sure you get your mammograms, up to date. So it's more of a flowing thing rather than, there you go, that will fix you.
I like that approach because I found with my experience is that when a doctor or a GP helped me realize that it was perimenopause eventually, it took quite a lot of adjustment and trial and error to get the right treatment.
Absolutely, yes, that is very correct. We sort of think, I mean, it's great when somebody actually even comes up with an idea, oh, okay, it's perimenopause, you could benefit from hormones, but I think there is still some progress to be made to see each woman as an individual, because, even if you're looking at perimenopause, it could easily be a 10-year window. You could be at different stages of that journey, and, you may be lacking all of the hormones. You could be lacking just one or two of the hormones, and you may not need all of them. And actually giving you all of them may make your symptoms worse, may exacerbate some of your, some of your symptoms that you're experiencing. So I think it's very important to sort of go individual with each case.
So tell us about the testing that you do then.
Okay, look, it's nothing too majorly. I mean, we can go. I've got access to all the fancy tests like Dutch tests. I'm not sure if you heard of. So it's dry urine testing, and it allows you to test the hormones over a few days. So you've got a bit of a pattern rather than just that snippet in time. This is what it is today, because I mean the very definition of perimenopause is those fluctuations that women experience. So one day your estrogen may be super high, A week later, it could be in your boots, and that will give you different symptoms. So there's obviously limitations, and we generally we are not encouraged to test. We just say, look, there is no test for perimenopause. It's likely to be perimenopause based on your symptoms. So the treatment for it is the hormones. Off you go. I just, within the limitation of the testing, I like to test, because and it just depends obviously where you are in a journey. So, for example, my approach will be slightly different to with somebody who still has fairly regular periods and maybe even gets signs of ovulation, like the sort of the sticky mucus sort of scenario. I may check your hormones 7 days after, for example, and check what your balance is between your estradiol and your progesterone. So often what we can see in perimenopause, you may have super high level of the estrogen and very low progesterone to balance it out. So there, although we just did it on that one occasion, and again, your estrogen may fall later in the cycle, especially before the period, so that's common, and that's what can bring things like migraines, for example, on. It is helpful to see, because that estrogen dominance may be one of the symptoms, one of the signs, and then what happens is you may get heavier periods. You may have then situations where you're having to have iron infusions and having to have a procedure to deal with this overgrown lining of your womb. You may get sore breasts, you may get the irritability.
And that's from estrogen dominance?
Can be, okay. Absolutely. And then, so it's quite common, they don't it's not a situation where you've got, those two hormones are just seizing all in the same time and you just don't have them anymore. Like the whole menopause definition is, the 12 months after the last period. And it doesn't mean that you used up your last egg and that's it. On average, a woman still has about 1,000 follicles, 1,000 eggs left in the ovaries. So there's still some activity going on.
In menopause?
Oh, absolutely.
I did not know that.
And this may actually complicate in a way. This is why it's different for every woman. So you may get your HRT and your friend may get your HRT. You may be exactly the same age, have similar symptoms, but you may respond slightly differently. I'm not even talking about different absorption rates, through the skin, everybody. So it's good to, I think, have that a bit of a baseline and then recheck in 10, 12 weeks, or depending on the symptoms, and then just check how you're responding to things. So yes, that's so I just do basic tests. Look, there's limitations, especially with, as we're learning, testosterone. It's a tricky one because the type of the lab assay that the majority of labs in Australia are using is not particularly accurate. Okay. So with testosterone is slightly different. I tend to go on the symptoms. So the main one is the loss of libido, and that's the one that's this is the main indication for use of testosterone in a perimenopausal or menopausal woman. But anecdotally, just from many patients that we see, it helps the bit of a muscle mass, that sort of mojo, that get up and go in the morning, that mood. So testosterone is slightly different. Estrogen, progesterone, we can easily check. And like if I see a blood test and I see your estrogen through the roof and your progesterone very tiny, often that is the problem. And then talking to the lady and then just discovering, actually, the main issue with her is she's got sore breasts, she's got very heavy periods, she may be irritable, she may not sleep very well, she may have insomnia, and it may worsen right before the period. Those are the things that can be indicating low progesterone, for example.
Okay.
So each individual, nothing necessarily too fancy. I go simple if I can. If there are tests that can be covered by Medicare, then we do that. We don't necessarily have to go and spend $500 on Dutch testing if we can do just those simple tests.
I think for some women, I think that's great. Probably for the majority of women, that's great. I think I wish I had met you in the early stages of my perimenopause, because I feel like I was the kind of person that required that regular testing to figure out exactly what was wrong, because my body is very sensitive to estrogen, and I get really bad. Not bad. I get heart palpitations, and my anxiety goes through the roof. So for me to take estrogen is just it was a no-go for a lot of my perimenopause time. But I'm scared to not take estrogen because I know the benefits of taking it. So I would have loved to have had that testing and understand why does estrogen do that to me, and maybe it was the whole estrogen dominance and the cycle. So I think, and that's why I think that, and maybe I shouldn't be advising people on here, but I think seeing a menopause specialist for women who are really struggling is the best thing that they can do, because I didn't know any of that you've just told me.
I mean, look, we all have different approaches in the way, there are guidelines, but I think they're still sort of emerging, and generally we are told there's no need for testing, but I disagree with it to a degree, because I think, well, it's cheap and cheerful, okay, and it can give us the information that we need. And we're so different, we're not all the same. We're not responding the same. I had a lady, and we put her on some estrogen. I think she was on 2 pumps of estrogel, and we organized some bloods, and somehow she ended up with one of my male colleagues, bless her, and she basically said to him, look, I feel pregnant. It's not good. It's not a good feeling. What do I do? And he just checked the levels that I've organized for her. Well, said, your estradiol is 2000. Well, that means it's working. Well, that's a sort of pregnant lady sort of level. So that just shows it was too much for her. Those two pumps of estrogen for her was just too much. I'm hoping things will look up, because everybody's more. I just came back from International Menopause Conference in Melbourne in October, and the turnout was much bigger than a couple of years before. Well, it was COVID times, I guess, as well. But when they actually analyze who attended, there's more students, there's more trainees. So we're hoping there's this whole new generation of specialists coming onto the sort of working market that will be clued on and be eager to help. And
that's exciting. Testosterone. And this is actually going to bounce a little bit, because I read some information about the importance of sex and sexual activity during perimenopause and menopause for your vaginal health, but also for emotional health and connection to your partner. But during that time, it's the last thing on your mind during perimenopause. So I'm just curious, like, what are your thoughts on that? And what are your thoughts on testosterone? Because it is, I know you mentioned testosterone earlier, but it seems to be a controversial hormone to give women. The combination of that with the sexual health.
I think we're quite lucky in WA, actually, because testosterone is actually being made in WA, so they sort of pioneering it. And so we had, reps come in and talking to us about it. Because it's not available in every country. I think there's still issues in America. I remember doing a menopause course through Marion Gluck Clinic. It's like a British bioidentical hormone clinic, and they were talking about bringing testosterone from Western Australia. Actually, I'm like, wow, that's amazing. So no, I'm very much pro testosterone. There doesn't need to be much fear with regards to that, because it's a women's only product. So the level of the hormone it's much lower. I believe that in some countries, and don't quote me, it might have recently changed, but there was a period of time when it wasn't available, like the testosterone gel for ladies wasn't available for women in New Zealand, but they could access male product. And I'm just thinking, this is just a minefield. This can go wrong, because we're going to have a lot of angry, hairy ladies, running around. Because how do you even just sort of make sure that you dose it correctly? You can start very little at a very low dose, and I just. Given that we don't really have, there are tests available. They're just not easily available to monitor the levels. I just really base it on women's response. If you if you try it and if you feel, look, it's really helpful, then go, continue using it. There was a conference specific to testosterone, a couple of them actually on that menopause conference, and they were saying, well, there's a lot of research in a pipeline. At the moment, what they can see is it definitely helps the libido. They cannot say much about all those other aspects we were hoping it will improve, but just seeing the ladies and speaking to them, you can tell it does, it helps the sort of, as I said, that sort of mojo, that get up and go, that foggy brain can be often linked to lack of testosterone. So that energy levels, just that ability to do things, that you used to enjoy. So I'm very much pro testosterone, definitely.
And what about sex and sexual health during perimenopause? Do you have any thoughts on it?
I mean, it's just a massive piece of the puzzle in terms of the general well-being, isn't it? I mean, just how we've been designed. I mean, going back to testosterone, I mean, the highest level of your testosterone are normally in the 20s, because the sort of nature created us the way that, your libido should be the highest then, because that's when you procreate, But different women have a different sort of levels of decreasing of the testosterone as well. I think it's important and useful, and as you say, create that sort of closeness and the fundamentals of the relationships. How many times, how many relationships have been affected by, the women's loss of libido, and I think we still design the way of putting ourselves on the back burner. So although women go to the doctors more frequently than men, they tend to go more if there is symptoms that affect their family unit, so their relationship, for example, with the partner, with the children, for example. So if things like the intimate relationship is at danger, they're more likely to go and speak to somebody, I think. Because with the last one, so if it starts affecting others in the family, like for example, you're so irritable that you snap at your children and all that, and you don't want to be that sort of mother. I see big increase in that sort of mental health component of the perimenopause as even sometimes sole reason to present to discuss the perimenopause, menopause.
Wow, because the woman comes in wanting to put her family first.
Yes, I think that's how we've been designed. So that's my take on it.
Can you tell me a little bit more about estrogen dominance? Because I get that question quite a lot.
So when you think about a woman's cycle, and in the context of perimenopause, sometimes you may have longer cycles, sometimes very shorter cycles. The ovulation may not be happening every cycle, and you really need that ovulation to produce the progesterone, because the progesterone is being produced from the sort of inside of the follicle after it pops. It's not just the perimenopause specifically. There's other conditions in which progesterone may be lacking, like polycystic ovarian syndrome. That's, I guess, for another talk. But what you get in estrogen dominance is that you don't have the balance of the progesterone to nicely even out the estrogen function. So, for example, heavy periods can happen because the progesterone acts protectively on the lining of the womb. So then we see a lot of ladies with things like adenomyosis, for example, which is a condition which is like an endometriosis on the inside of the womb, where you get that ingrowing and the sort of some thickened lining growing into the muscle of the womb, and then that causes heavy periods, for example. And that can be an issue on its own, with having to have iron infusions, having procedures like ablation or even hysterectomy at the sort of extreme situations. You can get the fluctuations of the hormones, you can get headaches and things like that. But the also frequent thing is the the lack of the progesterone, because the progesterone crosses blood-brain barrier and gives us that sort of calming effect. It gives us it sort of counterbalances any anxiety, helps insomnia and all those things. So you see a lot of that in estrogen dominance.
Okay.
And also it gives you more tendency to put weight on, for example, that sort of estrogen dominance gives you the sore breasts and so it's just so important to give you the balance. And this is why there's one of the misconceptions that if you had hysterectomy, for example, that you don't need a progesterone, where the progesterone is so excellent at balancing the estrogen.
And I'm curious to know about your thoughts on bioidentical hormones versus pharmaceutical.
I've done some training in it. I did training through Marian Gluck Clinic, which is very popular in the UK. So I know my basics of it, and I do use it. I do use that knowledge, and I do prescribe it. It is not my first choice. I think in a sort of bit olden days where there was very limited choices in terms of the HRT, and you were looking at oral estrogen, which we know now is not the best for you, just the way it's being metabolized. I would say bioidentical HRT tailored to specific women's needs was definitely a better solution. But nowadays we've got some really good products on the market. So I would normally generally start with those first.
Okay.
It's also the cost element of it as well. And I think it's important also to obviously have a discussion and see what your expectations are, and if you are requesting the bioidentical HRT, what are your reasons behind it. But definitely if you tried the mainstream products and you had issues with them, then by all means bioidentical is something to be considered. It doesn't have the best press, whether it's in this country, when you actually Google it and say bioidentical HRT and what's the sort of current knowledge about it, and the attitude from like the Australian Menopause Society, you get some negatives there. I've just been to the International Menopause Conference in Melbourne, and there was a separate room and talks about bioidentical HRT in South Africa. So it's quite difficult to sort of extrapolate that on all the other countries, but the vibe was generally very negative.
Okay.
And how sort of scammy it was supposed to be, and how people were in it just to make money, and there was no need, and this and that and the other. So I took that with a pinch of salt, really, because there may be other reasons in that specific environment that this is happening. It's a shame to sort of then make assumptions on the actual function of the hormones. And often the doctors who do prescribe those medications, they have the good knowledge and understanding, and it's not just, okay, well, there's your 2 pumps of estrogen and your progesterone, and bye for now. But I will actually look at what do you need, how do we adjust it to make it specifically work for you. So that's my take on it.
So a lot of women are very scared of HRT, and what do you say to those people?
I think it's important to have a discussion and see, why, because obviously we've been conditioned that way over the years, and that obviously stems from the infamous WHI study that was just saying that HRT is just the worst thing ever. And for years the attitude was, well, gosh, if you're really that weak that you cannot deal, then we're giving you the smallest amount, the shortest period of time, and are you sure you really want to take that risk? So it's important to see, well, why. I had a lady coming in actually last week, and she said, well, I haven't ever even considered HRT because I may have BRCA gene mutation. So I said, you may have. Which says, well, my cousin has one. But she's never been tested for it.
Yeah.
We don't even know whether she's got it. But it was an easy excuse for everybody to just dismiss her, because the moment she said that I may have it, oh, okay, you cannot have it, so let's move on and talk about something else.
Yeah.
Well, I think we need to know whether you have it, so we can do something about it, and you cannot just live your life on an assumption that because of this you may you may not explore that option.
So would you recommend gene testing then for people?
Well, that was a specific scenario. So for her, yes, because it was her grandmother and then cousin on the same side of the family that... I'm not sure about the grandmother, whether she had a genetic testing, but the cousin definitely did and had breast cancer early in her life. So, we can refer to genetics even under Medicare, and they're generally very useful kind of people. And they will assess on each individual case whether somebody would benefit from having the genetic testing. I wouldn't say, oh yeah, all of you should have a BRCA gene tests to establish whether you can have an HRT. No.
Okay.
And also, there's a big misconception of people thinking, even health specialists for example, breast surgeons, they're just sometimes so opposed and just bring the fear out in ladies. So I have a lady who in her 30s ended up with a breast surgeon, had completely benign Leo lump, and was told, you will never be able to be on HRT.
Yeah.
And I found it so bizarre.
Yeah.
Because there was nothing suggestive of sort of precancerous, cancerous, and how can you say to somebody in your 30s and just give them that?
Yeah.
Like you will never be able to be. So then you make your choices. Who you refer? You try to refer to people who are open-minded and will not say things like that, because that can be quite damaging.
Yeah.
Definitely.
Okay. Yeah, I suppose they have to find themselves in a place where they feel comfortable with that choice. They have to.
Yes, and there's a lot of information out there that circulates still. That's not true.
Yeah.
In terms of breast cancer risk, for example.
Yeah.
So all that has to be discussed.
So you're an advocate then for HRT?
Absolutely, yes.
Yeah.
Yes.
Okay, let's move on to perimenopause symptoms. Why so many symptoms? Why the itchy ears? Why the frozen shoulder? Why the hip pain? Why? Like, why do we suddenly fall apart so quickly in so many places?
I think the simple answer to this is we don't realize that in majority of our body parts we have hormonal receptors. We think of estrogen and progesterone in context of breast tissue, ovaries, the reproductive organs. We may think of bones because we've been hearing about it more lately, but those receptors are everywhere, including the brain, for example, hence the brain fog or struggles with memory or retaining new information, or mood disorders. So the receptors are everywhere. So it's that general aging that you have of the whole body when you're in that state of depletion in terms of the hormonal levels.
So does HRT, by replacing the hormones or by supplementing them at least, does that slow the aging process?
Absolutely.
Okay.
Yes, it does. So we're replacing something that's no longer there and it's missing. And we're struggling with that concept for whatever reason. But when you think about it, with any other body parts or any other aspect of our life, if you've got a bad knee and you need a knee replacement, nobody says, well, it's a sort of natural process, so just live with it,
Yeah.
That's what God wanted, or, however different approaches people have to it.
Yeah.
Or, if you, and I know those are extreme cases, but obviously if you're lacking in insulin, we're giving you insulin, you may die if we don't. If you lack in thyroid hormones, we give you thyroid hormones. How are we so different? And we are very different from a generation of our mothers, grandmothers. We live longer, we work longer, we're supposed to just juggle absolutely everything. And we're living in the 21st century. Why not take advantage of those findings? The research that goes on.
That makes sense.
Why suffer?
People ask me strange questions. I mean, obviously I'm not in a position to answer them, but I'm going to ask them to you now. People say, does putting estrogen on your skin help with anti-aging?
There is some research suggesting it might do. I mean, just from a vanity point of view, no amount of collagen containing cream for $500 will do the same as the estrogen will, because estrogen actually makes new collagen.
That you put it directly on your skin?
Not necessarily on the. I mean, some people do, and some use that as well. But just generally being on HRT from within helps producing new estrogen. So that anti-aging process, just happens everywhere. There is some talks and some use, and I believe Marion Gluck Clinic, which is again that bioidentical clinic in the UK, they use sort of compounded products. It's tricky, I guess, because if you look in sort of at gels and things like that, they may not be sort of compatible with the skin itself, but there is some, and you have to be careful with some discolorations and things like that. So it's individual basis, but in theory, yes, the estrogen does make new collagen within the skin. It helps.
What are other things you can take during perimenopause to supplement what's happening to you?
The way I see it, I think it's very much individual basis. Whether it's supplements and whether it's vitamins. It's good to run just the basic panel, because sometimes the symptoms we could be attributing to menopause can be deficiencies. I think it's important to stay on top of your protein intake, because we know that from menopause onwards we're losing on average 0.6% of our muscle mass each year.
Wow, that's
so so we're recommending about 1.2 gram of protein per each kilogram of body weight. It's so important because there is that general deterioration in the muscle, and the muscle is super important, obviously, for our general health. So definitely staying on top of the protein intake, definitely staying on top of the gut microbiome situation, just as just to sort of balance things. Very important there. So no extremes are good, not just protein and that's all, because you can starve your gut microbiome and you can just shift it in the all wrong direction. But good protein intake, but also plenty of fiber, variety of fiber in your diet. On average, we should be aiming for about 40 different sources of fiber in a week.
Wow, that's a lot.
Does sound like a lot. That should be the aim. And we can cheat, as in, today you can have a green apple, tomorrow you can have a red apple, and they're two different fibers, and they will feed different types of the gut microbiome. So those are the things in terms of general supplement. Otherwise, it's not uncommon to be lacking things like magnesium, for example. And that will affect your ability to then have the strength in your muscles and the ability to exercise and all that. So good to just not just focus on the hormones, but just do a general checkup, just see what else could be there that could be exacerbating some of the symptoms, making things worse.
Okay. Now this question, I don't really want to hear the answer to.
Oh gosh.
Alcohol.
Okay.
What do you think about alcohol during perimenopause? Because everybody says you should stop drinking, but I love my wine.
Oh, bless you. Okay, look, it can exacerbate the symptoms, especially the sort of vasomotor ones, so the hot flushes, night sweats, because of the effects on those tiny little capillaries, those little blood vessels within the skin. So it can make things worse. It is a individual risk factor as well for things like breast cancer. So look, anything in moderation. You're looking at. I'm trying to be positive. Yeah.
You're trying to give me an answer I might want to hear.
You know, when you're looking at the sort of Mediterranean populations, they love the glass of wine with the meals. I think everything in moderation, but again, individual as well. As in, you know, if you really feel that it's affecting your symptoms, you may have no other option but abstain.
Yeah. Well, I find if I don't have a glass of wine, I struggle to get to sleep. If I have more than 2, I struggle to sleep.
The balance, yes.
Yeah, so if I have the one, I'm good.
So it probably works as a bit of a muscle relaxant. You don't get that really nice restful sleep though after alcohol. So, you know, there may be other options like, you know, a little bit of melatonin or magnesium.
Yeah.
Maybe progesterone is not where it should be. And that can affect the sleep quality or the ability to fall asleep in the first place.
Yeah. Okay. Well, because that was going to be in the next topic, was sleep, was how, because so many women complain about sleep during perimenopause, and what I've experienced is just waking up all the time. But probably the worst thing is the 2 to 3 a.m. thing, where you wake up and just cannot get back to sleep again, and the brain just does not want to switch off. What is happening, and why does our sleep pattern change so much? Is it just progesterone? Is there more to it?
Well, there's more to it, but that's an easy one to just consider and then adjust if needed as well. Because again, we're all individual. So you know, a dose of progesterone for one lady may be not sufficient for another. But it's a big part of it. You know.
Okay.
Obviously, you know, the other simple solutions, you know, like having the sun exposure first thing in the morning. Some people find the sort of cool showers first thing in the morning. Just, you know, anything that can help that stimulate that production of melatonin, because that's naturally sort of going down as we get older. And, you know, just making sure that you're physically that little bit tired as well, you know, to have that more of a restful sleep. I do experiment with progesterone sometimes as well. So, you know, if you tell me, you know, sometimes ladies come in and that's the main thing. If you can just fix my sleep, I'll be a happier person, because it just affects so many other.
It does.
So many of the other aspects of our life.
Yeah.
And, you know, the progesterone is low, we can adjust it. You know, it may take some time as well for the progesterone, especially if you've been lacking it for a while. You know, you've been battling those symptoms for a while. Those receptors on the cells, they sort of go rusty, they deteriorate a little bit, they go to sleep a little bit. So it may take some time to sort of awaken them.
Okay.
It may take up to 6 months.
Wow, that's a long time.
It can do, yes. So, and if somebody, for example, haven't had a progesterone on board for a while, then they're more likely to maybe get some side effects at the beginning as well.
Okay.
So there needs to be discussion about it. And then, you know, if you feel like there's been some improvement but hasn't sort of gone where it should be yet, you know, we could try higher dose as well. And again, each individual.
Yeah.
So often progesterone is a common one, you know. Providing all the other sort of, you know, sleep hygiene and everything else is being looked into. And
yeah, I think for me that's the biggest thing. If you could fix my sleep, I'm going to be able to wake up in the morning.
Yes.
I'm going to have energy. I'm going to be able to exercise.
Yes.
My brain's not going to be foggy. I'm not going to want to eat all afternoon because I'm so tired.
Yes.
And eat the wrong things.
Yes.
I feel like there's so much can be fixed just by getting the sleep right.
And you know, it's just that sort of holistic approach. It's not good for, you know, for me to just say, oh yeah, just do those, do meditate, and, you know, get your sleep right, and then you feel better. Well, this is how we, you know, we just need to try to achieve that balance by having just the right amount of the hormones and all the possible things you can do lifestyle wise. But often those hormones are the first sort of key step, so you can actually do those lifestyle things,
Yeah.
isn't it?
Yeah.
And then things may start looking up, hopefully.
Okay, we have to wrap it up soon. But I know that a lot of people are going to also want to know about weight and weight gain with perimenopause. Why is that happening? What can we do about it?
So I mean, just a general, in a sort of layman terms, there's that general slowing down of the metabolism. I would never ever say to anybody, "Oh, start HRT, it will magically make all those kilograms disappear off you," because it would just simply be untrue. But if it does give you a better sleep, if it does give you some more energy so you can go for your long walks, and you may feel less foggy brain and less exhausted, so your food choices may be better, then that's a bonus. That's definitely helpful.
Yeah. Okay. That's awesome. I want to ask you 50 million other
bless you.
questions. But I don't
Maybe we
have
should do
time.
it
We don't
again.
have time.
Oh, bless.
We've got work to.
That is true. That is true.
But thank you so
Pleasure.
much. I'm
Pleasure, my
so
pleasure.
grateful.
I was so excited to do this.
Yeah, but thank you so much. I really
my
appreciate
pleasure.
it.
I really enjoyed it.
And,
I feel like we just need to come out of our comfort zone and just do things that just push the needle that little bit further,
Yeah.
isn't it? And just
And it's so helpful to women out
hopefully,
there.
Yes.
Yeah. There are not enough women GPs on there
Yeah.
talking about it
Yes.
and helping us. So
Yes.
you are doing a wonderful thing
Oh, wonderful. Thank
for
you so much.
135,000 followers.
Wonderful. I feel blessed. Thank you so much
Yeah, thanks
for
Anna.
having me and just giving me the platform to
So we'll see
talk
you
about
again.
it. Absolutely.
Thank you.
Lovely. Thank you.